ROS1 fusion have been identified in up to 2% of non-small cell lung cancer. And standard of care ROS1 TKIs are resulting in limited durability of response due to acquired ROS1 resistant mutations. Repotrectinib is a next generation ROS1 track TKI with a compact macrocyclic structure that completely fit into ATP binding pocket. So this design improves the durability of benefit by decreasing or circumventing ROS1 resistant mutation. And then it also has enhanced intracranial activity. So TRIDENT-1 is a global Phase I study. And in this trial, we enrolled locally advanced or metastatic solid tumors harboring ROS1 or NTRK fusions. Repotrectinib was further evaluated in 4 expansion cohort of ROS1-positive NSCLC defined by prior therapy. So this year, WCLC, we are focused on cohort 1 and 4 with primary endpoint of the study of confirmed objective response rate. So in this trial, we enrolled representative patient of advanced ROS1-positive NSCLC. 24% and 46% of patients had brain metastases per Berg in cohort 1 and cohort 4. And regarding resistant mutation, G2032R front mutation were identified in 11%, and majority of patients were treated with crizotinib in patients with 1 prior ROS1 TKI and no prior chemo. So first, looking into the tumor response per Berg in TKI naive patients, this is cohort 1 data. Repotrectinib induced a significant tumor shrinkage in the vast majority of patients, regardless of prior chemotherapy. Among 71 TKI naive patients, confirmed objective response rate was 79%. Median duration of response was 34.1 months, which is far longer than those reported previously with conventional ROS1 TKIs. Coming to the median PFS and OS in TKI naive patients, median PFS was 35.7 months with 18 months PFS rate of 70%. This data is unprecedented result in TKI naive setting. Median OS was not non-evaluable. Next, coming to the tumor response per Berg in patient pre-treated with one prior ROS1 TKI and no prior chemo. This is data from cohort 4. The repotrectinib, again, induced a significant tumor shrinkage in the majority of patients, regardless of ROS1 TKI. Confirmed objective response rate in this cohort was 38%. Median duration of response was 14.8 months. Median PFS and median OS was 9 months and 25.1 months respectively in patient with 1 prior ROS1 TKI and no prior chemo. It is important to look at the intracranial efficacy of repotrectinib in both TKI naive and TKI pretreated patients. So we evaluated intracranial efficacy of repotrectinib in patients with measurable brain metastases. Intracranial objective response rate was 89% and 38% respectively. Intracranial responses are maintained in 83% and 60% at 12 months in cohort 1 and cohort 4 respectively. Next, we explore the potential of repotrectinib in preventing CNS metastases by looking at intracranial PFS in patients without baseline brain metastases. 12 months intracranial PFS rate was 91% in TKI naive and 82% in patients with one prior ROS1 TKI and no prior chemo. In an analysis of time to first intracranial progression only, none occurred within 18 months of repotrectinib treatment in both TKI naive and TKI pretreated patients. So next, we look at the emergence of new ROS1 resistant mutation at progression in 14 TKI naive and 43 patients across three TKI pretreated expansion cohorts. No TKI naive patient who progressed on repotrectinib developed an on-target resistant mutation. Among 17 TKI pretreated patients with baseline G2032R mutation, confirmed objective response rate was 59%, and median duration of response and PFS were 7.6 months and 9.2 months, respectively. Regarding the safety of repotrectinib, repotrectinib was generally well tolerated. Treatment-related adverse events leading to dose reduction, drug interruption, and discontinuation occurred in 31%, 33%, and 3% respectively. No events of dizziness or ataxia led to treatment discontinuation. The most common treatment emergent adverse event was on-target tract inhibition-related dizziness in about 60% of patients, with only minor grade 3 or worse treatment emergent dizziness. So in conclusion, TRIDENT-1, with a median follow-up of over 20 months, repotrectinib continued to demonstrate durable clinical activity in patients with ROS1-positive NSCLC in both TKI naive and TKI pretreated setting. Repotrectinib led to durable intracranial response and may have delayed or prevented the development of brain lesion in patients without baseline brain metastases. This implies early initiation of repotrectinib can reduce morbidity and mortality due to CNS progression. Repotrectinib was generally well tolerated. So these results from TRIDENT-1 demonstrate repotrectinib as a potential new standard of care for TKI naive and TKI pretreated patients with ROS1 positive advanced NSCLC.